Dr. Han. If anybody has any questions, please feel free to step up to the microphone. So we have Dr. Choi, who joins us from UCLA, Dr. Saab, also my colleague at UCLA. Dr. Yanny joined us recently, UCLA Santa Monica. Dr. Han is from USC. So I guess I'll start off with the questions. I had a question. So obviously, after this talk, it appears that bilirubin is important in prognosticating PBC. So it seems like the indication for secondary therapy in PBC is incomplete alkaline phosphatase response. So I wanted to ask the group, do you just look at alkaline phosphatase to decide whether to add second-line therapy like obeticholic acid, or do you also include bilirubin? Dr. Bowlus?
So alkaline phosphatase is probably, normalization or lack of normalization is probably the most common indication for me to use a second-line therapy. So patients that are relatively early in their disease, early fibrosis based on non-invasive imaging, but don't have a complete response, so their alkaline phosphatase remains in the 200s, 300s, sometimes higher, but still have a normal bilirubin. That's the most common indication. But there are those patients that, despite having relatively normal alkaline phosphatase and have advanced fibrosis, I do have a lower threshold for treating those patients and considering them, in need of second-line therapies. Though I have to admit they haven't been included in the clinical trial, so it is, not a lot of evidence to know how much benefit they're getting. Fortunately, with the FDA labeling, it mentions incomplete response or inadequate response, but doesn't define what that is. So we're not bound to being tied to sort of the definition that was in the clinical trial. So there's some room for clinical judgment there.
Dr. Bowlus, can I ask a question? So how do you assess fibrosis in your PBC patients? We talk about how FibroScan is not well validated in this group, and biopsy them all.
No, I would say there's at least one study from France that does show a decent correlation between FibroScan and biopsy histology in PBC. In PSC, it's maybe a little bit less well understood because of the heterogeneous fibrosis that occurs in PSC. But in PBC, FibroScan seems to work reasonably well. We actually had an abstract at AASLD. It was a 2-year prospective study of about 45 PBC patients where we did both FibroScan and MR elastography annually, so baseline 1 year, 2 year on these patients, and there was really great correlation between both MRE and FibroScan. It didn't change much over 2 years, even in those that didn't have a complete biochemical response to URSO. So my feeling is we didn't have histology to compare, but we had other indicators that would be very helpful in terms of histology. Now, the other important thing, and I use this quite a bit, is that GLOBE score, because people haven't done biopsies in PBC for a very long time, so histology may not be that helpful, but I think we can define when someone's got early cirrhosis, advanced fibrosis on these non-invasive imaging measures also to help guide it.
Sammy?
Can I highlight something that Chris said, and I think it's very, very important, is that, there's a lot of controversies. How do you define our URSO non-responder? There are like 6 guidelines out there. They're not consistent, 1.67, 2 times upper normal. And I think what Chris said is very, very important, is that, for NASH, or fatty liver, hepatitis C or B, we will never stand for an ALT of 75 or 80. We want a normal ALT, normal AST. And I think Dr. Bowlus is correct in that, our goal is to try to normalize OG phos as best as possible, because as he showed and Vinay showed very elegantly, the OG phos is probably one of the single best predictor of outcomes people with PBC. So our goal is to get it as normal as possible. In terms of, who do we think about obeticholic acid, other medications, it's predominantly AGFOS. If your bili's really high, it may not be safe. We don't know the efficacy or safety utility in patients who have advanced cirrhosis, giving them second-line agents. So the predominant thing is AGFOS.
Can I ask the panel, how much time should you give before you rule the patient to be an incomplete responder? Do you keep them going on URSO for 6 months, 1 year, 2 years?
So as Sammy was saying, there's a variety of models to determine if the patient had a response to ursodiol. What I have noticed is that in the majority of those models, they determine response based on 1 year of treatment. The only one which has a shorter time frame is the Mayo risk score, which is around 6 months of treatment. So in general, I look at anywhere from 6 months to 1 year of treatment with ursodiol before I determine if the patient has not had a response.
Yeah, that sounds pretty reasonable.
And as far as the dosing of URSO, do you, before you call it quits and add a second line, do you try increasing the dose of URSO? And is there a maximum over which it wouldn't be beneficial to go any higher?
So I'm not aware of, Dr. Bowlus showed some nice data about high doses of AGFOS, URSO being associated with poor outcomes in PSC. But I'm not aware, correct me if I'm wrong, Chris, of any data like that for PBC. That's showing that higher doses may have a negative impact. So I would, without blinking an eye, use 500 BID. In rare cases, we've only gone 500 TID. But it's a pretty safe medication, except for high doses in PSC. For PBC, I think it's pretty safe.
I would agree. I think it's important to recognize it's a weight-based dosing, though. So, you may have a patient, and patients' weight changes over time. I've had patients either gain weight and become unresponsive because they're taking the same dose of URSO.
That's a good point.
You just increase the dose of the URSO, and then they respond again because they were underdosed. So, I think if you have a non-response, make sure that you are using adequate doses, and that would be 15 milligrams per kilogram per day.
Yeah.
You could try increasing slightly. I think, the downside of URSO and PSC was at really high doses, so twice what we would use normally. So if you went to 20 milligrams per kilogram daily, that's probably okay. And you might get a little benefit in a few patients, but I'd be surprised if you do. So there is some room for altering the dose there.
I usually stop at 15 milligrams per kilogram, and I usually see a response in my responders within 6 months. So, I do wait a good 6 months for them to see a response or not. And I definitely have not used bilirubin as a measure of whether I move on to a second line. I do think those that are not responding as far as ALK-PHOS, I have seen whether it's within normal range, but a higher normal for bilirubin. So I think it goes hand in hand with the ALK-PHOS.
But measuring compliance is critical. Yeah. Taking any drug twice a day, I take a drug for cholesterol, and I forget it like half the time. And there's only one pill at nighttime.
Sammy.
But, so I couldn't imagine taking a pill twice a day. I think it's very difficult.
Yeah, and I think that's the other thing about if your patient can only remember to take it once a day, that's okay. It's supposed to be twice a day, 3 times a day in some cases, but as long as they're taking at least once a day, I think that's all right too.
I do my dosing once a day, we practice in the county system, LA County, and I will say that it's very tough to know if there's response because of compliance adherence issues, and so it's very hard to measure. Are they really adherent, or is it that they're unresponsive? So it's definitely a tough situation.
Very similar to Dr. Han, I also stop at 15 milligrams per kilogram. I start initially at 12 to 13 milligrams per kilogram and monitor. And I also do not use bilirubin as a marker to start a second-line therapy. I do use bilirubin to look to use more advanced imaging like MRE or an MRI of the liver with contrast to make sure that the patient has not developed a stricture or cholangiocarcinoma.
Dr. Pagros has a question.
Yeah, it's just for Chris or anybody on the panel. I also have used fenofibrate in a couple patients that couldn't take OCA after they had an inadequate response to URSO. Then I made the mistake of looking at the label on fenofibrate more carefully and reading it beyond the top and realized it was contraindicated in PBC. So, and I'm using it for an off-label indication. So if I get in trouble, they're probably going to call on you to testify against me. So I want to know, am I on shaky ground or what?
Boy, I haven't been to law school. I don't know. Medically, I mean, I think there are enough people in the country that would come to your defense. I'd be one of them.
Is this being recorded right now?
I'll come to your defense, Paul. So we did a review of the literature on this, and and there's a recent publication in New England Journal of Medicine about a similar drug. At low doses, 54 milligrams a day, it's very safe. We've used in about 20 patients, 30 patients. It's worked in 95% of patients. Yes, low dose. When you see problem with kidney issues, are the higher doses. So we never go much higher than 54 milligrams a day. Very well tolerated, very safe. Tell patients that when they go to the pharmacist, it's for the PBC, because they think it's for cholesterol.
I would say that if you do use fenofibrate, there is a rate of hepatotoxicity, and that was seen in bezafibrate, was seen with seladelpar and other PPAR, that at doses that are used for the treatment of hypercholesterolemia, hyperlipidemia, again, this was in seladelpar, they had a pretty high rate of hepatotoxicity, reversible, but elevations of the ALT. And that's why this next study was using doses much lower. So I agree with Sammy, the lowest dose possible. So when I've used fenofibrate in the handful I've used it, it's always the lowest. So I think it's actually 48?
I think it's 40, sure enough, I think 50.
Anyway, the lowest dose possible, and monitor very closely their transaminases. I get a liver panel monthly on those patients once I start them to be sure they're not having one of these adverse events.
And kidney function.
So with fibrates, you do get elevations of the creatinine, but actually that's likely due to increased production and not necessarily to any renal dysfunction. So there's been some issues with that. With the seladelpar, they did look at whatever it is, cystatin or whatever you use now, and that doesn't change. So I'm not sure if the kidney.
I think it's a warning on the label.
Okay.
Nephritis.
Okay. I'm not aware of that one. So anyway, I think that I agree. I think that there is some evidence on fenofibrate. There's a difference between fenofibrate and bezafibrate that we have to be careful with. So there's limited data, and Cynthia Levy's working on getting. We'd like to get you guys involved so we could get this. There's a lot of people using it sort of off-label. If we can gather that data, give us some more confidence.
I mean, would you feel more, I guess, safer, because I think Cynthia Levy's data was on PBC patients with dyslipidemia, that those who have dyslipidemia, you would have more, even though it was a small study, I think it was like 20 patients that she looked at, but would you feel more legally comfortable to say, well, hey, there's the indication for dyslipidemia in the PBC patient, sure, let's use it, and there's some data to show that.
Yeah, and I would say that in some of these patients that I've considered, they also have cardiovascular disease, and so it's usually working with their cardiologist, and sometimes I get their internist or cardiologist to prescribe it.
But if I had for second line, my first choice would be obeticholic acid. That's FDA approved. Can I highlight one thing, Steve? I want to make sure that when we talk about PBC, we recognize it's a systemic problem, and not just liver. We got to make sure we ask our patients about dry eyes, dry mouth. Are they getting their thyroid checked, their bone density? It's a systemic problem, ask about swallowing, cold hands, stuff like that.
Yeah, because, our old mentor, Dr. Reynolds, he discovered the Crest syndrome in association with PBC. So I was going to ask the panel, how many of you utilize the symptoms and signs of the Crest syndrome as part of your diagnostic algorithm for PBC? I've used it a lot. If a cholestatic patient comes in and they have Raynaud's and blah, 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 it's PBC unless proven otherwise. Any comments?
I mean, I think these extrahepatic manifestations the association is known, and so I go as so far as check a TSH every 2 years.
Question?
Are the PBC-specific ANA labs available in Quest Diagnostics and LabCorp, or is it a specific lab that you order it through?
So for the SP100 and GP210, I use RDL Diagnostics. They're in Los Angeles, and they'll run both a recombinant AMA, which is the most sensitive and specific test, which generally you don't get, as well as the PBC-specific autoantibodies. I think LabCorp might run it too.
They do. LabCorp does. I've never ordered it, I'll be honest, but I do that LabCorp does offer it.
For the panel, I know I'm on the panel, but how many of you are actually checking the SP100?
I haven't checked it.
I've never.
I haven't.
To be honest, I've never checked
So-
it. Yeah.
We should?
I
We
do.
should? Maybe we
That's what I
should.
figured, but.
So I don't, it's not something I do routinely. It's
Yeah.
those cases where, I know this is a PBC patient because they come in with the tight skin and the dry eyes and they've got an alk phos and all the rest of the stuff, and their AMA is negative. And if their ANA is positive, I send that off. And that way I avoid having to do a liver biopsy. Now, that's a small handful of patients, but to me, it was worth the effort to do it. Now, half the time it comes back negative, and I do wind up doing the liver biopsy. But I've had some interesting cases where it was really difficult to come to a diagnosis of, like in a man I had once. He couldn't figure out what was going on with him necessarily until he came back and told me his mom just died from PBC. And I was sure he had it, but he's still AMA negative. Biopsy was kind of, consistent with, but not, no floor duct lesion or anything like that that was slam dunk for PBC. And turns out he had SP100 and was, now I'm sure now he's on obeticholic acid too. So.
I have a question for the panel too. So how greedy do you guys get with the alkaline phosphatase? I know that 200 is what the literature supports, but our upper limit of normal in our lab is 113. So are you guys strict with the 200 or?
Like Bowlus said earlier, we want that normal as possible. So, I would want something in the 120s, 130s. I think 180 is way too high. 200 is too high.
I think I think it's easier to think about it as a continuum, and there's not a specific, once you get above the upper limit of normal, that risk curve starts going up, and so, as Sammy said, we do want it to get down to normal, kind of like an A1C, right? I mean, we want to get it as normal as possible, and it's part of the. If I have a patient with advanced fibrosis that's got an alk phos of, 130, 140, I'm likely to want to be much more aggressive in trying to get it to normal, especially if they're a younger patient. If I have a 70-year-old woman who's got stage 1 disease and their alk phos is, 130, I don't know how much harder I'm going to push on that patient to get down to normal. So I think it's, like all these things, it's kind of the clinical context that you have to put this all into place and to make those medical decisions. But I agree, in general, we want to drive that as low as possible.
Can I bring something else? So you wrote a very nice paper about 10 years ago. I think it's a Sentinel article, about people with PBC developing autoimmune later on.
I wrote that?
Yeah. Great paper. And we've seen it. People with PBC for a long time, and also they can have a flare of the AASLD and develop this secondary process. So we have to recognize that you can develop, on top of this, de novo autoimmune.
Yeah, and I would say that, as opposed to the overlap, I think you can have, patients with PBC or autoimmune hepatitis or any autoimmune condition are prone to have other autoimmune conditions. So I think you can have coexistent PBC and autoimmune hepatitis, and if you look for AMAs even in just autoimmune hepatitis, you'll occasionally see them. It doesn't mean they have PBC too, or, you know.
You know, we had a patient die at UCLA about a year ago I've been taking for PBC for many years, and his liver test went to 1,000. And his primary doctor thought, oh, it's drug reaction, left him alone, never called me, and then unfortunately, went to liver failure, passed away.
So if you have a patient that you've decided to pull the trigger and start obeticholic acid because of incomplete response to ursodiol, they're doing well with the lower dose, you now go to the higher dose. Well, their alkalos has not responded appropriately with the lower dose, but they're not having pruritus. You go to the higher dose, and now you get a good biochemical response, but the patient starts to have itching. At that point, what do you usually do? Do you add cholestyramine? Do you expect the itching may actually get better with continued treatment?
So sorry, Vinay. So I would first ask when is itching occurring at nighttime or during the whole day? If it's at nighttime, it's a simple thing adding Benadryl or Atarax. If it's during the day, you don't want someone driving around with taking Atarax every 8 hours. So if it's during the day, and then I think about cholestyramine, which I don't like, cholesterol is okay, and I love Welco. And if that doesn't work, and then we just go down the pathway, rifampin, natriaxone, and Zoloft.
Would the itching get better just with continued treatment?
Yeah, if they're responding. So the good thing about obeticholic acid, the side effects are predictable and they're manageable. They get better with intervention. So before we start therapy, we talk to the patient about the side effects. Make sure you guys call us if you have any problems, so we could intervene. Beshoy, what do you do, Vinay?
I was going to say virtually the same thing, that essentially that if they are having a biochemical response, you should try to treat through it and see if you can improve their symptoms.
Same here, definitely try to treat through it if the patient's had a biochemical response, unless their lifestyle is completely hindered by the pruritus. Despite our best efforts, then I continue the medication.
Okay.
And going back to the fenofibrate question, just like
Oh,
anything.
that's too late. We've asked that. It's like 3 questions
Never too late, never too late.
It takes me a while to think, sorry. No, but just like with anything in medicine, as long as we do a good consent process with the patient and let them know what data we have and the patients are usually very smart and we can tell them, look, this medicine is not really approved for this indication, but there has been studies recently and they're still collecting data. We've tried everything else. It's not working very well for you. We can give this a try and see if the patient is responsive to that. And if the patients are very worried about it, then they generally will tell us, no, I don't want to use it. Yeah. And as long as we document that clearly, we can definitely use fenofibrates. I mean, more than half of the things that out there for advanced endoscopists, I don't know if they're advanced endoscopists here, like the esophageal stents for esophageal variceal bleeding, they're not on the label, they're not approved for those uses, but as long as we talk to the patient, do a good consent process, I think it would be reasonable to use it.
We have, I wouldn't call it an epidemic, but we've been seeing a lot more IgG4-related disease, patients coming in with a cholestatic type of pattern. I know we touched upon that a little bit, but I want to ask the panel, Dr. Bowlus, what is your treatment algorithm if you diagnose IgG4? Do you give them steroids to start? Do you maintain maintenance immunosuppression?
Yeah, so I have to say my experience is pretty limited to just a handful of patients with IgG4, really, sclerosing cholangitis. My experience has been they respond well to prednisone. They need to be maintained on azathioprine. I have 1 or 2 patients where they have also needed a low-dose prednisone. Haven't been able to get them completely off prednisone. And it's been pretty gratifying, and actually their symptoms are so exquisitely sensitive. They know when it's coming back. At least my experience, they have the same kind of symptoms they had that brought them forward when their disease is getting active again. Just follow their IgG4 levels and you see them go up and down. So that's been my experience, but again, limited.
Yeah, I've had limited experience as well, but I recall a patient I recently had I just did a course of steroids, and I actually didn't continue azathioprine. He was an older gentleman in his 70s. I sort of, this was the first episode, I guess, he had had and he had had a full workup and a lot of intervention. So we tried the steroids. He got a lot better. We've monitored his labs. He's done really well. So I haven't continued immunosuppression with him.
So you tried the steroids and then tapered the steroids, and the symptoms and the biochemical tests
Everything.
remained good, and you were
Everything.
able to completely stop the
Yeah,
steroids.
stop the steroids. Mhm.
I know there was the IgG4, serum IgG4 cutoff that you mentioned. We actually had a patient who had a low IgG4 in the serum, and there was a big question. Our colleague, Dr. Durazo, did an ERCP with biopsies of the stricture, and it came back, the IgG4 stains on the histology were well above the, 14 IgG4 per high-powered field, so we made the diagnosis histologically. So, but we're seeing a lot more of it for some reason.
But that highlights how hard it is to diagnose IgG4. It's
Yeah.
very difficult.
Yeah.
Steve,
Yes, Chuck.
the comment is, though, that in autoimmune pancreatitis, the serology is only positive 40% of the time, and yet 4 weeks of steroids gives you great evidence that that process was in place. And I would submit that we're underdiagnosing this particular condition.
So if it's positive only 40%, how do you diagnose the other 60%?
Steroid response and an ugly-looking pancreas that's there and would look like classic autoimmune pancreatitis.
Yeah, I would say that this is still a really difficult issue for us to deal with.
It's
And
hard.
even on histology, so there's been some studies looking back at well-documented explanted PSC, and they also have a high frequency of IgG4 positive plasma cells there.
Yeah.
And it doesn't always correlate with serum levels, so I think I think when if you have a patient with IBD, that's where the IBD really helps, because in the IgG4 sclerosing cholangitis, you typically don't have IBD. It's usually an older man. So if you have someone that's younger, IBD, and serum IgG4 that's only mildly elevated, or maybe moderately elevated, I think it's probably not IgG4 sclerosing cholangitis, but we're still not sure that there might not be a benefit of steroids in that group. There's a little bit of data there, but it's still an unknown.
That's interesting.
And even the biopsy is very patchy, so you may miss it.
That's true.
The IgG4, you'll miss it, the stain.
It's tough.
Kelvin. Oh, sorry. Beshoy, do you?
Good, sorry, I didn't mean to cut you off.
Nope, go ahead.
So I actually have a patient in the hospital right now, and I think the use of steroids previously has really helped me to kind of come up with a diagnosis of PSC and not IgG4. Her IgG4 levels were in the 2.4, between 2.4 and they hovered, in that range between 2.4 to 3, and she's been through multiple medical centers, got many doses of steroids over the past 10 to 15 years. Unfortunately, she's now cirrhotic, getting evaluated for a liver transplant. But in patients like this, and she does have IBD, I was a lot more inclined to call her disease PSC, because the steroids, she does have IBD, the steroids didn't work, the IgG4 is not a slam dunk. So after, and I'm not sure if there's a threshold of how many steroid tapers do you use before we can call it PSC and not IgG4 if there is no response. But, for me, I thought maybe 2 times where it didn't work, then it's probably PSC. So that's one of the uses that steroids can sometimes lead us to make a diagnosis in that case. Just like autoimmune pancreatitis. If there's a response, it's probably that. If there's no response, then it's PSC.
Kelvin, you have a question?
Yeah, I do. So Dr. Bowlus, you mentioned about the 3-year data on the obeticholic acid earlier, but I just wonder what's the endpoint of it. I mean, it's still early to say, but do you have patients that actually ask you, like the drug is expensive, and down the road, like when can I taper it off, or when I can stop the medication? Do you have patients asking you those questions?
So I think there's a couple of things in there. So as far as we know, there's no end of treatment, just like there's no end of therapy of URSO or treatment of diabetes or hypertension or hyperlipidemia. These are chronic diseases. We're not curing them. So they'll likely need to be on obeticholic acid or some other therapy lifelong. I've had patients that were in the POISE study for 5 years or other studies and have continued on it. So, 6, 7 years or so of treatment. And they've all been doing quite well. So far, insurance has not been an issue in terms of cost. That's likely to change in the future. Or actually, if it's approved for other indications, maybe it'll get better. I don't know. So the patients that tolerate it and do well on it, no problems long term. I think the other part of the question is, is it translating into some clinical benefit long term? And that's something that's quite difficult, and we don't really know yet. We have, growing evidence to suggest that. There are some clinical trials, 2 different trials going on now, treating patients with more advanced disease that would be expected to have sort of clinical events. But the hard part about doing clinical trials with a drug that's available commercially is to do a placebo-controlled trial. And that's really the stumbling block we're having in terms of really knowing the clinical benefits of these drugs, and it'll continue to be a problem. So all we can really probably do is compare it to historical controls, look at real-world experience sort of thing to give us more information on that.
I really like that data that Vinay, you showed us on the MRI predictors of PSC. So I see my colleague, Dr. David Liu, our radiologist at UCLA. I just wanted to ask, David, do we have this yet? No? You thought you were just coming here to relax. I just want to ask.
Yeah, that's my first disclaimer. Yeah. Sorry, what was the question?
Can our MRs predict PSC like Vinay was showing that abstract? Do we have that capability?
Yeah, it's based on the MR cholangiogram, and the Japanese have published a lot of data on how there are ways to distinguish the features of IgG4 versus PSC. However, in my experience, they're very, very difficult to distinguish between the two. And only if you find certain features can that be helpful. But otherwise, it's almost impossible. But what we do look for are the extrabiliary findings.
Yeah. But we don't have that ability to do the, we have.
You mean the elastography?
Oh, actually, that prognosticating model of PSC, with the Anali score with and without gadolinium that Vinay was showing.
No, we can do that. It's only a matter of whether you want to sit down and actually go through each of the features and account for them and do the measurements and provide a score. So, I think it's one of those things where it can be done. All the features that was mentioned are going to be present on a good MRCP.
Okay. Well, I don't have any more comments. A question? Yeah.
So in a true case of IgG4 cholangitis, does anybody follow the radiographic changes as before you stop therapy? Do you look for complete resolution of radiographic changes?
In my patient that I have in the hospital now, she came to me after she's been to multiple medical centers, so I had the ability to look at her previous MRCPs, and she did continue to progress. In fact, she has a critical stricture right now that our advanced endoscopist was unable to get through the stricture, despite using the steroids multiple times in the past. But that's why I'm also more inclined to call her PSC and not IgG4 disease.
Yeah, I would agree. I would look for radiologic improvement as well. In the study that Dr. Bowlus presented, that same group wrote a nice review article about IgG4 sclerosing cholangitis, and they did recommend that not only should you look for a biochemical improvement, but also you should look for a radiologic improvement before you consider stopping therapy.
Right, there's no guideline for it, but, that is one of the treatment endpoints, right? And so, but the question is, when do you get it? Do you get it a month after? Do you get it 2 months after you start the prednisone? And so I think it'd be reasonable to do it a month after to see if it's even working and take it from there. But there's no guideline to really direct you on that.
I would just also say the other consideration to think about is cholangiocarcinoma, be sure you're not missing that. And so follow-up imaging is always a good idea in those cases. Can I ask a different question?
Sure.
You mentioned rifampin for pruritus.
Yeah.
I don't know if many people use that. I mean, management of pruritus and cholestatic liver disease, excuse me, is really challenging. So when do you use rifampin, and are there people you wouldn't use it? Is there a certain stage of liver disease where you say, no, it's just too risky?
So we usually go up an algorithm, start with antihistamines, bile acid resin absorbents, and our third line is rifampin. We always start at a low dose 150 BID. I'll be honest, I have not seen hepatotoxicity with rifampin. People are really sick, MELD score is 30, 35, I'm less likely to use it. But for the most patients, we started, and the dose is limited by nausea and vomiting. And we also need to warn them about wearing contact lenses because it does change your tears to orange. Yeah. But it's, most people respond to Welco and Atarax, and so I don't use that rifampin a whole lot. I do not like Zoloft. I don't think it works at all. I think those guidelines are based on one abstract. I think it's a waste of money. I like naltrexone. But we've had patients who took one pill, actually a quarter pill, and started hallucinating. So we got to warn them about that. In fact, we prescribed us one on Friday, but it's rare to use naltrexone. Usually we stop at rifampin. 150 BID and it's work, and then maybe go 300 BID, but it's limited by the nausea. What's been your experience with rifampin?
So my algorithm did include Zoloft.
Yeah, I like sertraline. I believe in sertraline.
Use it with you? Yeah, I use it.
It doesn't work for the itching so much, but a lot of times patients feel better. So
They're happier.
I have used it. I've had like maybe 1 or 2 patients seem to get better with it. I have to say the binding resins patients generally don't like to take.
The cholestyramine?
Cholestyramine.
Yeah, that's why you gotta use Welco.
Yeah.
I
tried that too.
I don't like to use cholestyramine.
People hate it. If it's bloated, is it powder? You gotta mix it.
Well, you can't, essentially, you just can't take anything else.
No.
Everything, it's always binding to something.
All of them have the same issue where you have to separate it from your urso and everything else, so it becomes problematic there. I've been using the rifampin more and more, and I think it does work well. And then the usual conservative measures too, in terms of
Avoiding wool and
No warm baths.
warm bath at nighttime. But if you look at quality of life, pruritus is a big component of that, and fatigue and leg cramps. So we have to be on top of this and remind patients that have pruritus. It could be from the liver. They think it's an allergy, something they're taking.
Is that why you use Benadryl?
We use Benadryl.
So, Chris, you were actually the lead author on the seladelpar study, and it looked pretty promising in terms of improvement in pruritus. What was your experience, being an investigator in that study?
So the study's ongoing, and so a couple of things. One is bezafibrate's also been reported to improve pruritus. The seladelpar study is a placebo-controlled study, and so I would say that measuring itch is really difficult in studies, in clinical trials, and there's been a couple now using these intestinal bile acid transport inhibitors to try to treat pruritus and cholestatic diseases. And I mean, there's one ongoing now actually for PBC. They're just very difficult to quantify, and you get this, just like in any other symptom, you get a huge placebo effect. Yeah. So anecdotally, I would say that a few of my patients that have come in very pruritic without any kind of comment from me, I think, have come in saying, yeah, I've had an improvement. So I think it's real, but it needs to be verified in further studies.
I think we should also mention, don't forget, that intractable pruritus, ultimately, the cure may be a liver transplant. So, that's a patient that you should probably refer for evaluation.
When was the last time you had a patient transplanted?
Exactly.
Around here.
We try.
I think that's my segue into the pitch for the living donor program. So refer your patients to USC's living donor program, especially our cholestatic liver disease patients who are not controlled on these beautiful drugs that have come out, because you need to really, they would benefit from transplant, so please do so.
Well, I think we've worked our panel pretty hard this morning. So if there are no more questions, we are 5 minutes early, and so we are on break, and we'll be back in about, I guess, 25 minutes.
Thank you, Steve. Thank you.